and into addressing those additional costs. So I'm going to begin today by sharing information about the ADA, our policy priorities, and then I'm going to focus on talking about the policies that we support that can address access specifically to insulin. That has been where a lot of our efforts have been so far. And it is important for me to note that a lot of the bills that you'll hear me talk about today, as of today, this moment, the Idaho legislature has not passed some of them. But I don't want you to feel discouraged, because there should be, I hope, an opportunity to see some of the opportunities that we all have and that we can advocate for and hopefully change them. And I, of course, will be sharing information that about some bills that have been passed in Idaho and some other resources that can be helpful for working with your patients and helping them identify affordable access to medication. I'll also be taking some time to look beyond insulin and at some of the costs around diabetes supplies and technology. And then, of course, we really can't talk about access to medication alone. Really, at the root of all of that is access to health insurance. So it's important to acknowledge that, and I'll be talking a little bit about that today. And then after I get done talking about those topics, we're going to move into how you can be an advocate for your patients, friends, families, and yourself. And you are already advocates in the work that you do. The advocacy I'm going to be talking about is specifically how you can advocate for policy change at the legislature and at the local level, and even take action and do things at the federal level. So I'll share information on how you can sign up to be an advocate, what that looks like, how to contact your legislator, and other steps you can take to improve access to affordable medication and care. Our organization, its work, sets us apart from other diabetes organizations, and we truly are mission-driven and work tirelessly to move towards achieving that mission. Diabetes is a public health crisis, and just some statistics for you. So compared to non-Hispanic whites, American Indians and Alaska Natives are twice as likely to be diagnosed with diabetes. Compared to non-Hispanic whites, Blacks and Hispanics are more than 50% likely to be diagnosed with diabetes. And compared with non-Hispanic whites, Asian Americans are 10% more likely to be diagnosed with diabetes. This impacts everybody, and bringing up these facts, it ties into our health equity mission, which I'm going to be bringing up in a little bit, and that has really changed and shaped the way that we are addressing our policies going forward. The ADA's mission is, of course, to prevent and cure diabetes and to improve the lives of all people affected by diabetes. We're internationally recognized and a trusted authority in diabetes care and education. Each year, the ADA publishes the standards of medical care and diabetes and evidence-based guidance for healthcare providers, and informs diabetes care and education specialists around the United States and the world. And the breadth of ADA's work, we are a leader across multiple areas in research, advocacy, outreach, healthcare, provider, education, and training. And today we're going to be really focusing on that advocacy piece. So where do I fit into all of this? So as we were mentioned before, I am a part of the American Diabetes Association's government affairs team. There is 5 of us that are all state lobbyists, and we work really only at the state level on both legislative and regulatory issues. We do provide support to our federal team as they work on issues with CMS or with Congress. We may provide some support there, but really we're focused on the state and local level. And my job is to identify policy opportunities that will help people with diabetes. I sometimes oppose bad policies. So for example, if they were going to cut Medicaid access for continuous glucose monitors, because that is not a mandated policy, it's something that can be cut by the state legislature, maybe during a time of a budget deficit. So things like that, we monitor for, we will advocate for or oppose. And then I work with legislators and regulatory bodies. And really the most important part about my work is connecting volunteers and members in each state to this legislative process, learning from our members and our advocates about what is important, what is happening in each state, and the experiences that their patients may be having. Those stories can really help shape the policies that we are working on. So let's jump into the advocacy priorities. So these are kind of policy buckets is how I look at them. So each one is kind of an umbrella topic. So health equity or prevention, this is like the umbrella, and underneath each one of those is the specific policies that we work on. So for example, under the prevention bucket, we work on access to the National Diabetes Prevention Program, universal school meals, or access to nutritious food in schools. So those are kind of the actual policies that fall under these different areas. And I do want to note, and I'll be getting into this a little bit more later, but the health equity piece, I really think that even though it's called out as a standalone advocacy priority, it does tie into each one of these areas. And I'll be getting into that more later when I share our Health Equity Bill of Rights. Well, now let's take a look at diabetes in Idaho. So we know that about 9.6% of adults in Idaho have been diagnosed with diabetes. And the second statistic is one that's going to get brought up later, and it has to deal with the health insurance. And it's that 36,000 people in Idaho have diabetes but don't know it. This can be very dangerous. As many of you know, they probably aren't seeing the doctor, they aren't managing the disease. 33.8% of adults have prediabetes. And then every year, an estimated 11,250 people in Idaho will be diagnosed with diabetes. The cost. So this is going to be a conversation that we're going to be having throughout today. And I'm sure you have all heard stories from the people that you work with or in news articles about the cost that people face managing their chronic disease. And these data points show that those aren't just anecdotal stories. Unfortunately, it really is a broader systemic issue that people with diabetes are facing. And that is why it's so critical to focus on policies that will alleviate the cost so people aren't forced to make choices between insulin and paying their bills. So the first two statistics on here around the medical expenses for diagnosed diabetes, these are more the impacts on the state. So the state of Idaho, the cost for diagnosed diabetes is $956 million. And then additional $314 million is spent on indirect costs. So that's usually tied to people missing work and things like that. Diabetes accounts for $1 in every $4 spent on healthcare in the US, and it is the most expensive chronic disease in the United States. And then this last point, and it's one that we're going to be, of course, talking about throughout, is the cost of insulin. And between 2002 and 2013, it nearly tripled. And as I'm sure many of you know, the actual product of insulin hasn't changed that much. So, and we'll be talking about this in a little bit, but one of the pieces of legislation that we try to strive for is price transparency. So we can really get at the root cause and the list prices of these medications. And overall, people with diabetes, the medical costs that they face are about 2.3 times higher than for those who do not have diabetes. So in 2020, in response to the impact that the pandemic had and its disproportionate toll on minority, low-income, and historically underserved Americans, the ADA launched Health Equity Now as a platform. And a key piece of that is the Health Equity Bill of Rights. And this really has served as a framework for the work that we are doing now and going forward. And there's two pieces of this that I want to share. And I think that in general, this resource is important to share with everybody when I'm invited to come speak at opportunities like this. But there's two areas in which we're going to be diving in more today. The first is the right to access insulin and other drugs affordably. That's number one on this list. 1 in 4 insulin-dependent people with diabetes say they ration their insulin, and we're going to be talking a lot more about that statistic today. And some additional data came out, a new paper came out that talks further about it. People with diabetes should be able to get the medications they need without having to choose between filling their prescription, paying rent, or putting food on the table. The other piece is the right to insurance that covers diabetes management and future cures. Diabetes is the most expensive chronic condition in the US. People with diabetes incur medical costs almost 2.5 times higher than others. Costs skyrocket for Americans who have diabetes but do not have insurance. They're hospitalized at a much higher rate. We've heard a statistic of about 168% as often, compounding the risk for complications and leaving them medically worse off than if they sought care earlier. So to start bridging disparities in diabetes care, it is essential that all people with or at risk of diabetes are covered by robust health insurance. Well, let's talk about insulin. And I think part of the reason why we started out focusing some of our policy work around copay caps for insulin is because it really is a matter of life and death for people who are insulin dependent. And it also, over the last couple of decades, as we were talking about, the cost of insulin has been steadily rising, putting this life-saving drug out of reach for millions who need it. And I think there's one point in here on this slide that really stands out to me, which is that when people aren't able to afford their insulin or having these costs rise, it creates worriness, stress, anxiousness, and hopelessness for these individuals. They're already dealing so much with managing their disease that the idea that they also have to worry about how they're going to be able to afford filling their next prescription is something that we really need to resolve. And more than half of people impacted by the cost had at least one recent visit to the ER. And that, of course, just speaks to the fact that if they had their insulin, they'd be able to manage their disease, stay out of the hospital, stay healthier. So what are some things that we can do? And I'm going to be focusing only on a few of these, but we've identified some different policies that can help address this. So one is streamlining the biosimilar approval process, increasing pricing transparency throughout the insulin supply chain, lowering or removing patient cost sharing for insulin. That's going to be a big piece that we talk about today, and increasing access to healthcare coverage for all people with diabetes. Again, another point that we're going to be focusing on today. I'm also going to be talking about a couple of bills, including one that the state of Idaho has passed that deals with access to insulin at a time of an emergency, which can help alleviate some of these issues. Although it's not a permanent solution, it can help. So as of today, there are actually 22 states plus the District of Columbia that have passed copay caps on insulin. This map is not fully up to date, so I believe there's only about 20 states currently on this map. But Colorado was the first state to pass law, and since then we've seen both blue and red states that have passed this legislation, showing that it really does not need to be a partisan issue. I do want to note that not all copayments are the same in every state. So for example, Colorado was the first state. They passed a $100 cumulative copay cap. So what that means is, say you have a patient who is on a few different types of insulin and they go to fill their prescriptions for the month at the pharmacy. That cap would be $100 for all those different prescriptions of insulin. Other states have passed a $35 copay cap. That seems to be what we've seen more often. And in fact, Washington, who originally had a $100 copay cap, actually went back this last session and reduced it. So the $35 seems to be kind of what we're seeing being pushed, including at the federal level, which I'll be talking about shortly. And I also want to note that this copay cap typically, not in all states, but typically is applied pre-deductible. So the patient doesn't need to meet a deductible and then get to have this low cost cost sharing. They get to experience that before they've met their deductible, which is ideal and what we advocate for people with diabetes. So what do we know so far about copay caps? So copay caps are really getting at the cost sharing for people with diabetes. In my role at the state level, we are only allowed to pass laws that apply to certain types of health care or health insurance, So states only are able to regulate state-regulated plans. So those are often the ones that sold on the Affordable Care Act marketplace, or they can regulate Medicaid, but they cannot regulate ERISA plans. And ERISA plans are typically like what a lot of large companies, self-insured insurance. And so in order to have these caps apply to everyone, there has to be, of course, the action at the state level. and then the federal government has to step in and pass legislation that helps kind of fill in those gaps. And it has helped people to afford their insulin, but of course we know there's many, many other costs associated with diabetes care, and we're going to touch a little bit more on that later. We also hear from groups that oppose these copay cap legislations that if a state passes it, it will raise premiums for everyone getting their health insurance through the marketplace. We hear that every time we go to a state legislature and pass one of these bills. But the good news is that states that have passed them have, there's been studies that have come out, insurance companies, they actually have to publish certain information. And what they found is that these copay caps have either had no impact on raising premiums, or if it had an impact, it was considered negligible. It was not enough for plans to be at all concerned. And in fact, health insurance companies have been just actively taking the step themselves and saying we're going to provide insulin to our members at a $0 copay. So what that shows us is that it really isn't about the cost to these large health plan companies. And we can provide or work towards providing people with affordable access to their medication without it having to impact others and raise their cost of healthcare. And so we're hoping, it's great to see these health plans do that. It helps reinforce this idea that we need to address this problem. But the great thing about passing this legislation is it ensures that this is a permanent change versus these health plans, while it's great that they're doing it, they can decide to take it away and change it at any time. That's up to their discretion. The cost of managing diabetes is unsustainable. And so advocating for legislation like copay caps for insulin is a way to help us alleviate some of those costs. So I mentioned earlier that a new study came out. I've received the information yesterday, and it found that 1.3 million adults nationwide rationed their insulin in the last year. They went a little bit further and found that delaying purchase was the most common form of rationing for all people with diabetes. And then for specifically people with type 1 diabetes, their number one reported form of rationing was that they were taking less than prescribed. So copay caps on insulin are just a first step. When we pass these bills at the state level, like I mentioned before, they only impact people on state-regulated health plans. But for it to have a broader impact, we really do need the federal government to also take action. And Congress has noticed that states have been taking action. As I mentioned before, we have 22 states plus the District of Columbia. Congress saw the growing number of states, and they decided it was maybe time for them to do something about it. And they did introduce a couple of bills throughout this spring and summer that would have had a $35 copay cap for everyone. Unfortunately, none of those bills made it across the finish line. However, in August, Congress passed the Inflation Reduction Act, which included a $35 copay cap on insulin for all Medicare beneficiaries. So before, there was a pilot program that people could opt into. It was not for all Medicare beneficiaries, but some, and they were able to get a $35 copay cap. But this now expanded it to everybody. You don't have to apply. It will just, when they go to purchase their insulin, they will be told that it will be $35. This will be taking effect in 2023, and it'll apply to all seniors on Medicare, including those who use insulin pumps. The bill also made changes to the prescription drug pricing in the Medicare Part D, which means that seniors may pay even less than $35 per month for their insulin beginning in 2026. If seniors get charged more than $35 after the law is in effect starting in 2023, they will get reimbursed. And the bill also caps the cost of all prescription drugs at $2,000 per year for seniors who have Medicare Part D. And this out-of-pocket cost limit will benefit people with diabetes who rely on more than just insulin to survive. It also allows Medicare to negotiate the price of some of the most expensive prescription drugs directly with drug manufacturers, reducing the cost of these often out-of-reach medications to seniors. And for individuals and families who have private insurance through the Affordable Care Act, the bill extends through 2025 premium subsidies that were expanded during the COVID-19 pandemic. And those subsidies have been really great in reducing the cost of health insurance for many people. And like I mentioned before, all of these are just steps that we're taking, right, towards a holistic improvement, which ultimately would probably come with addressing something with the list prices. But this is a great first step, and our federal team will continue to advocate for broadening this copay cap beyond just Medicare beneficiaries. So what else is out there? I want to start by bringing up a program, and I'm bringing this up because I've actually heard from some Idaho legislators that they had an interest in it. But in 2020, the Utah legislature passed a bill called Insulin Savings Program. And the idea behind it is really leveraging the negotiating power of the state to get insulin for people at a lower cost. So states run a public employee health insurance program. So this is for employees of the state, and they get their health insurance through it. And the Insulin Savings Program allows anybody living in Utah to get their insulin through the public employee health plan. And what's great about it is you go online, you fill out this form, you get a card, and then when you go to the pharmacy, you show them the card, and then they sell you the insulin at a lower cost. So anybody can get it, as long as I think you just have to have a valid Utah driver's license. So who this really could benefit is the uninsured population in the state, to help them get affordable insulin. And I believe this summer they said about 1,500 people had utilized this program, and they were really happy with the success of it, so much so that they're looking at expanding it and adding in other types of prescriptions, including they're looking at adding continuous glucose monitors, which I think could be a great way to provide that important technology to people at a lower cost. And overall, we're just seeing, like I mentioned before, Idaho legislators have asked me about this program for more information, but we're just hearing more interest from other states about it. So other programs that you can refer your patients to. So different insulin manufacturers offer various patient assistance and discount programs, and consumer costs can range for the programs. And I have included a link on here to insulinhelp.org. This is a landing page that the ADA has put together. It's incredibly comprehensive. It walks you through the details of each manufacturer program, the benefits of it, contact information, and where to apply. And it's somewhere you can direct your patients to, where they might be able to get immediate or long-term help with affording their medications. There's also phone numbers on there for device manufacturers who have patient assistance programs, so for CGMs, insulin pumps. And then there's a link for patients to find the nearest community health clinic or pharmacy, which I know Dr. Moore is going to be talking more about after my presentation. And then there's information also on there on other discount programs. So there's GoodRx, Blink Health, or Inside RX. There's more on there. And I believe there's about at least 10 discount programs listed out on that link, but there's more than that out there. I do want to note that the ADA does not specifically endorse any of these programs. And while we refer people to these programs, we still believe in advocating for more permanent policy changes that can really get at some of these root problems. And these programs are an important option for people to access affordable care, but they're not permanent. It's up to the manufacturers on how they're going to run these programs, for how long they'll run these programs, and who is eligible. And so because of that, because it's up to them to determine, we always are looking for answers to, solve this problem in a permanent way. And finally, I also included our number down there, the 1-800 number. So you can refer your patients to this resource. The ADA can help connect people to different areas, help connect them to a local community health center, help connect them to the manufacturer's assistance programs. And questions can be answered in English, Spanish, or any other language using a language interpreter. So that can be very helpful to help direct your patients to. So I'm now going to shift into talking about some policies aimed to address emergency access to insulin. So Kevin's Law, there is a form of this that was passed in Idaho. And this bill is really aimed at people who might have an expired prescription who couldn't get a hold of their doctor, but really need to get their prescription filled. And it really moves some of the professional judgment up to the pharmacist to decide. And the legislation typically includes some parameters. So I included some examples of parameters that might be there. So of course, there has to be typically an existing prescription in the patient's name, limits on the amount that can be dispensed, and how often you might be able to use this. So the Idaho bill was passed in 2018, and the change allows a pharmacist to fill a prescription for a non-controlled drug one time in a 6-month period, up to the quantity on the most recent fill, or a 30-day supply, whichever is less. And 40 states and the District of Columbia have all passed some form of Kevin's Law. Another law, this has not been passed in Idaho, but it's something, always that we offer up to legislators as an option, is the Alex Smith Law. It was passed in Minnesota after a 26-year-old passed away from rationing his insulin. And this bill is really meant to ensure that no one has to be in that position again. So you can get, again, an emergency fill, a 30-day supply of insulin for a $35 copay one time in a 12-month period. But then there's also a long-term program where individuals can get insulin from the manufacturer for up to 1 year with a copay cap of $50, and it's typically dispensed in a 90-day increment. And what I think is really interesting is that this final point, which is that within the first 9 months, 465 Minnesotans obtained insulin through the program, and 222 of those were using the program in a time of urgent need. And I live in Minnesota. I was in Minnesota when this bill passed, and I've had the honor to work with Nicole Smith, the mother of Alec, on continuing to address the cost of insulin. So no person ever has to be in this position again. And at this time, 3 states have passed some form of this bill. So I want to take a moment to talk about looking beyond medication, because of course that is a huge cost for people, but it's not the only cost. And looking at access to diabetes technology and supplies. So the ADA published a white paper after studying the use of continuous glucose monitors amongst Medicaid beneficiaries. Despite states, Idaho being one of them, having it as a covered benefit, people in state Medicaid programs are not being prescribed them or accessing them. In particular, the study found that people of color, poor people, and people in rural areas are less likely to get a CGM. And as I'm sure many of you know, CGMs are life-changing and very helpful for people in helping them better manage diabetes. So to address this, we've been looking at some of the different Medicaid criteria for CGMs and advocating for the removal of some of these barriers. And so I am going to be working on this in Idaho. Some of the barriers that currently exist for the state Medicaid is that it is only covered under the durable medical equipment benefit set. So what does that mean? Typically, you can have something covered as a DME or durable medical equipment, or through a pharmacy benefit. DME you have to then, if it's only covered under DME, it has to be filled at a DME location through a DME provider, versus a pharmacy. It's easier to get through a pharmacy, right? There's more Walgreens, CVS, more places that are a pharmacy licensed through the state to be a Medicaid provider. And in some cases, we can also advocate for mail order pharmacy in order for people to get their CGMs. I've also spoke with somebody who works for one of the manufacturers who provided me with some interesting information about the percentage of private insurance plans providing CGMs to their employees through a pharmacy benefit is significantly higher. And so they're seeing more pharmacies are carrying CGMs and have them in stock, so patients are able to get them faster. But really advocating for them to be covered under a pharmacy benefit and also the DME benefit will just improve overall access of where people can have their prescription filled. Removing criteria. So in Idaho, a participant must have frequent blood glucose testing of 4 times or more per day and must be treated with insulin injections 3 times or more a day. And there's also a limited formulary. And this really gets at the fact that the type of CGM should be left up to a patient and a provider to determine which that they use. And we want to ensure that any coverage for a CGM acknowledges that and allows for that to happen. And then under current Medicaid policy, there is a 6-month follow-up visit that must be in person. And we would be advocating for that to be a telehealth visit or in person. And a lot of this will actually be lining up with the CMS guidance for Medicare. So Medicare has already removed the blood glucose testing per day, the minimum requirement for that. And they actually just announced new guidance. It's just a draft. They haven't officially approved and passed it yet. But their proposal actually includes eliminating the 3 times or more a day for insulin injections, and then changing the injections to administration, which allows for people who use different types of insulin to qualify. And then their new proposal would also allow for the 6-month follow-up to be done by telehealth. So why that's important: 1, you may have Medicare patients that will benefit from these recommended changes. And 2, a lot of times state Medicaid will base a lot of their own criteria off of the Medicare guidance. So as I move forward with this project, this is information that I'll be sharing with state Medicaid, with state legislators, with other advocates in the state about how we can remove some of these requirements and alleviate the burdens for people to be able to access CGMs. And then a bit of a note just on kind of looking beyond the insulin piece for the copay caps. So we've seen a movement in states who have passed copay caps that are interested in going beyond that and looking at copay caps that apply to diabetes supplies and technology. And the governor of Delaware just signed a robust bill into law that is a copay cap, a cumulative one for all diabetes supplies and technology. And then, of course, health insurance. So having health insurance is the single strongest predictor of whether adults with diabetes have access to high-quality health care and are able to better manage their diabetes. Uninsured Americans who are at risk for diabetes and its complications are much less likely to receive a diagnosis. And if they do get a diagnosis, they still average about 60% fewer office visits with a physician, and which I mentioned before, 168% more hospital visits than their insured counterparts. While it's important to know about different policies that can address the cost of medications, we can also address costs by ensuring that people have access to affordable health insurance. So during the pandemic, Idaho provided Medicaid beneficiaries with continuous enrollment throughout the duration of the public health emergency. However, when that comes to an end, the state will have to redetermine individuals' eligibility, and we do expect people to lose coverage. This can be devastating for people with chronic conditions, as it can be very disruptive to their access to medications and healthcare services. We sent a letter to the governor urging the state to take steps to minimize the impact on people's insurance and ensuring that people do not wrongfully lose their health insurance coverage. And in a situation where they're no longer eligible, we really encourage the governor and the state to take steps to helping connect these individuals with other options. And of course, I mentioned earlier that part of the Inflation Reduction Act was the continuation or expansion of the premium tax subsidies. So that is something that will help people who might be losing the Medicaid coverage but are moving on to the marketplace still be able to get access to affordable medication. So what does this mean for you all? I would just encourage you to, talk with your patients, make sure that they have insurance, advocate at the state level to ensuring that Medicaid coverage continues. We always see threats to it. Medicaid was expanded in Idaho, which is wonderful. More people are able to access health insurance through it, but that doesn't mean that things can't be done to make it more minimal or to remove some of the benefits. And just make sure your patients have the right information. People can contact their health insurance and ask questions about their coverage, make sure that their diabetes care is covered. find out what their cost sharing is. Information is such a valuable tool and can really empower people to be able to make choices. So I want to pause for a moment to see if there's any questions at this point just on the topics that have been covered before we dive into how you can become an advocate. And I do want to do, before questions, just a quick recap. So Idaho has passed a form of Kevin's Law, which is great, that helps address emergency access. Your patients may have access to affordable insulin through drug manufacturers programs, other discount programs, or community health centers. And make sure your patient has access to health insurance and knows what their insurance covers for their diabetes care. And finally, as I mentioned earlier, that some of these policy areas are things that Idaho has not done yet, but that doesn't mean that there's not an opportunity to do it. And I really hope that this information today has inspired you to want to be an advocate, which I'm going to talk about next, and work together to make some of these policy changes happen. So are there any questions?
Thank you, Carissa. This is Dorothy Plaza. There is a question in the chat box. Beth is asking, when do you anticipate the CMS guidelines for insulin use for CGMs to change?
That is a great question that I can get follow-up information from our regulatory director and see if she has a timeline for that. I know we're submitting comments. She is working on that right now.
Thank you. And if there's any other questions, please feel free to add them to the chat box. There is a comment that someone's been bypassing the CMS guidelines through the COVID waiver. So is that something you could talk about?
Can you repeat the question?
That they have been bypassing CMS guidelines through the COVID waiver.
I am not as familiar with that. So I don't work on our federal CMS regulatory issues. So I'm not as familiar with that, but I'm guessing it's probably tied to the public health emergency. So that did alleviate some of the issues around like continuous enrollment and things like that. And so if it is at all tied to the public health emergency, that will be coming to an end. They have been, they just announced that it's been extended. So we don't know when that will come to an end yet. But if that is tied to that, that wouldn't be a permanent way to bypass that, right? And so hopefully with the CMS guidance being updated, that will help alleviate that when that public health emergency goes away.
Thank you. In light of that question, another person asks, can we bypass any CGM guidelines through Medicaid with COVID waivers?
I don't think I can give you advice to that extent.
We'll just let that, there's just a little discussion going on there in the chat box. Looks like it's been happening. And so, yeah, okay. Thank you for that.
That is great. Not great, but that's helpful information to know if people have been bypassing it. But I will say, so I'm coming out in a few weeks and I'm meeting with some legislators about this, with some doctors, some endocrinologists to talk about it. And my goal is to meet with the state Medicaid and talk about how could we potentially remove some of these. So then hopefully people aren't having to bypass them because they will just be eliminated, ideally. So that's something we'll be working on.
Great. Thank you so much for that.
Yeah. All right. So let's talk about how you can be an advocate. So I kind of mentioned this earlier, but what do I mean by being an advocate? So there's many ways in which people can advocate for patients. You already are doing that simply by being a provider, by coming to this today and learning about how to help your patients access affordable medications. But the advocacy that I'm talking about and encouraging you to engage in is advocating at the local, state, and federal level to change public policies and state laws. So each year, the Idaho legislature convenes, typically starts in January and goes for a couple months. And they consider different policy proposals. And then the state also puts together a budget. This budget usually funds Medicaid and other social service programs that have an impact on patients. So this is included on one of the later slides, but I'll make sure that you all have it. But you can sign up to an advocate. at a very long link that I'm not going to bother to read out, and I will just make sure it gets put into the chat. But as an advocate, you'll receive action alerts when there is a bill we want to support or a bad proposal we want legislators to oppose. An action alert typically asks you to contact your legislator and either urge their support or opposition. And they're made to be as simple as possible, truly what it is. So you would, to be an advocate in the first place, you go in, you fill out your information, your email address. It may ask if you'd like to share a story, which we always encourage people to do if you feel comfortable, or if you have a patient who has said you can share their story, of course, following the HIPAA guidelines and things like that. But the stories are fundamental in helping us change policies. It really helps paint the picture to legislators about what's happening and the reality of these costs for patients. And so if you sign up to be an advocate, you'll get an action alert, and that action alert will explain to you, here's the bill that's being considered, why that matters, what the change might mean. And then you just put in your name and your address, and it automatically then figures out who your legislator is. There's typically an email that's already drafted to the legislator with kind of the big picture, our ask, why we're asking. And then there's usually an opportunity for you to add in a personal touch about why you care about this issue. But the goal for us is to always make these as simple as possible to really encourage people to take action. So for example, on the federal level around these copay caps, we've had thousands of advocates across the country taking action, reaching out to their members of Congress, and that really is important. I have had times where a bill maybe isn't a top priority for legislators, but I send out these action alerts, call to actions to members. They reach out to the legislators, and it just elevates the importance of it, and has ended up resulting in maybe them bringing it to the floor, taking some sort of action because they heard from constituents that this matters. You can also reach out to me directly and share your interest. I always have opportunities, or I'm looking for people who are willing to testify during committee hearings, maybe have a one-on-one meeting with legislators, or work with me to author an opinion editorial for a local newspaper. And of course, this matters because you are the constituent, right? So your voice matters to these legislators. They represent you, the district that you live in. You are the ones that elect them and send them to office to work on your behalf. So your voice really does matter to the legislature. And you can find out who your legislator is if you don't already know, legislature.idaho.gov. If you go to their website, or I'll share this link, but it's a bit longer, but there's a Who's My Legislator part of their website. So you put in your address and it'll come up with everybody that represents you. And I think as I really painted the picture today, we have a lot of opportunity in Idaho to work together with the legislature to pass laws that will help people with diabetes afford their medications. And how do we pass these laws, right? Many of these laws have been passed in other states, so we already have language that we can use. If we don't have language, or there's tweaks that we need to make it really Idaho specific, that's something that I can do. I write legislation. As a lobbyist, it is my job to identify legislators who'd be interested in sponsoring or authoring the legislation, which really just means they're the point person for that bill. They are the one that moves it through the legislative process. They are the one who will introduce it in committee, speak about it on the floor. And finding a really good point person or legislator to carry a bill is important because they can really fight for the bill. They can use their relationships within the legislature to help move something forward. And if any of you know legislators or have worked with them in the past that you know are supporters of policies impacting people with diabetes, please let me know. A lot of times legislators I work with are people who are personally impacted by diabetes and really care about the issue. Sometimes a legislator contacts me about a bill they want to carry because we're a stakeholder organization, right? So they want to get our input, maybe get some data or expertise. But the reason that they're reaching out to me is because they have a constituent that they've heard from, and they've heard about this issue from somebody that lives in their district, maybe when they're out door knocking, or they received an email from somebody, and then they let me know, like, hey, this constituent told me about this issue and I want to do something about it. What can I do? Sometimes it goes the other way around. I'll reach out to a legislator and explain what the bill is and why it matters, and I ask them to sponsor the bill. So for example, I'm meeting with some legislators in a couple of weeks in Idaho. I'm going to be bringing to them, here are the options that you can do, these policy ideas that could address access to affordable medications in Idaho. Let's figure out what's going to work best for you and for the people of Idaho. The legislation has to go through a drafting process, and some states have certain deadlines that we have to meet. That's my job to know that, to make sure we're meeting all and any deadlines. And then once the legislative session starts in January, the bill it has to go through a bunch of different hurdles. So there's typically committee hearings in both the House and the Senate side. It's usually heard by committees that have some sort of jurisdiction over it. So most of the bills that I work on have to go through like the Health and Human Services committees, but it may have to go through additional committees depending on what the bill includes. So for example, if I was working on a bill to allow school nurses to delegate insulin, it would likely have to go through the Education Committee. Or if a bill has any impact on state funding, so any kind of Medicaid bill, it would likely have to be considered by a committee that is responsible for the state budget and revenue. And at each of these committee hearings, there's the possibility to testify and have providers or people with diabetes share their personal stories. Testimony can be done in person, virtually, or be in written form. So if people don't feel comfortable sitting in front of a committee room, they can write a letter and submit it that way. And I do want to note that sometimes during these hearings, you might find out that there is a group that opposes the bill, and they also have the opportunity to speak at that time. But it's always my job to understand ahead of the committee who may oppose a bill and why. So we can always include information, our talking points that can counter some of the points that they make. And at the end of the day, my job as a lobbyist is really just to provide education and facts and demonstrate why either supporting or opposing a bad bill is what the legislature should do. And at any of these points throughout this process, the bill can, what we call, die, it can be killed, where essentially the legislature won't pass to move it along in the process. But also something I've learned over my years is until the legislature signee dies, there's many creative ways sometimes to bring a bill back to life. And it can also be amended at any time throughout the process as well. And then finally, after it goes through the committees, the bill gets voted on by the entire House and Senate bodies. And if it's passed by both, then it goes to the governor's desk to be signed into law or vetoed. And that's kind of a very, very brief overview of what I do on a day-to-day basis and how we get a bill to become a law. I think in second grade, many people watch some video that kind of gets at that, but it's a little bit more complicated than some cartoons talking about how a bill becomes a law. So of course, coming here today and speaking with you all is one, to educate you, and two, to urge you to speak up and share your experience, to share the experiences of your patients. You can really help drive powerful and impactful change for people with diabetes by sharing your expertise and knowledge with elected officials, both at the state and local level. And together we can all really make a difference. And before we wrap up with questions, I just want to share some last facts with you. So 12% of people with diabetes reported having a disruption to their health insurance since the start of the pandemic. And at the same time, this point that I brought up already a couple times here today is that 1 in 4 Americans with diabetes reported rationing their insulin, other needed medications, or diabetes supplies since the start of the pandemic. And why does that matter? It matters because the burden and the cost of insulin was not a symptom of the pandemic, nor did it begin then, but it certainly has been exacerbated by it. And I'm sure we all watch the news and know that there's the potential of another kind of economic crisis, recession happening that can be really disruptive once again to people's jobs and livelihoods, which also might mean that people are going to lose health insurance. The end of the public health emergency is no doubt going to have an impact on people's health insurance. The end of this year, there's going to be an impact on people's SNAP benefits. So you're going to see people maybe not getting access to as much nutritious, healthy foods that they've been using to help them better manage their disease. So these tools today that we provide, this information and policies that we can address, can help us better provide the care and the support that these patients need. And it's essential that we find ways to address the cost for patients so they're not having to make choices between filling their prescriptions and paying for rent. People should not be rationing their insulin. We don't need to put that already on all the other things that they have to think about on a day-to-day basis with managing their diabetes. So I hope after today you feel that you have the tools to, one, of course, understand the policy options that can help ensure that patients have access to affordable medications. And I think one piece about this is permanent, to have a reliable source to know that this bill has been passed. And because this bill has been passed, I now know that I can get insulin for a $35 copay cap. That's really important protection that we can provide to people through lobbying. Understand what has been happening across the country to address this issue. And while I only focus on a few areas, there's simply so much more to talk about. And I'm happy to talk about other policies at any time if people are interested in food and nutrition, prevention, access to clean drinking water. It's really difficult to talk about only one policy area. As I'm sure you all know, it is so interconnected. If we can get more people access to the National Diabetes Prevention Program and preventative services and reduce the number of people developing diabetes and becoming insulin dependent, we have less people that are going to be needing to deal with the access to affordable medications, right? It's all so interconnected. And I hope that you will take action and sign up to be an ADA advocate or reach out to me directly. I hope that you feel empowered to reach out to your legislator, to share your story or talk to your patients and ask them if you can share their stories. And I thank you again for having me today.
Thank you so much, Carissa. And I want to make sure to leave any time if you guys do have any questions. You can either use the raise hand feature at the bottom of your screen, or you can use the chat box as well. But Carissa, while you guys are thinking of questions, I just want to let you know this was super inspiring. The Diabetes Alliance of Idaho doesn't have a whole lot of history when it comes to advocacy and policy work, just based on our history. And so being able to hear from you about some clean and clear options of next steps, I think that's going to really spark some discussion moving forward. And I'm personally grateful that you are an active member of the DAI that we can reach out to as a resource. So thank you again for your time and being willing to share on this important information.
Yeah, I'm happy to always be a resource. And if any of you have ideas or things that you hear, please always feel free to bring them to me.
All right. It doesn't look like there's any questions. We will have time at the very end in case anything else. Oh, Susan, you have your hand up. Feel free to unmute yourself if you have a question.
Hi, Carissa. I just wanted to comment, since you were talking about so many different types of legislation, because one of the things I've been struggling with some of our golden generation that's being serviced by Medicare currently is their teeth. So dentures and dental coverage. So I was wondering if you know of anything that's in the pipeline currently for that, because a lot of them can't chew vegetables raw or cooked because of the consistency of the food. So a lot of times they're going to like applesauce instead of eating an apple, or making those types of choices. So I didn't know if there's anything in the pipeline for that.
Yeah, I actually used to work for the Minnesota Dental Association. So I brought with me kind of the background of oral health and diabetes, which is very connected. So like I mentioned earlier, we have a woman who works specifically on CMS regulation stuff. So I will reach out to her and I can share the information to everybody today on that. I know in Idaho, I believe that adult dental is not covered currently under Medicaid, but in the spring when I came out to Boise, the dental association there, I believe, spoke, and we talked about it afterward. And that's something that we would, of course, support if it came up in Idaho. But I will get back to you on the Medicare front and see what I can provide.
Fantastic. Thank you. And thank you for everything you shared today. It was great.
Happy to be here.
Great question, Susan. And yes, the DAI also is working actively with Delta Dental, the Idaho Oral Health Alliance, as well as a few other key partners in the Diabetes Oral Health Connection. And we're going to be pushing out a rack card. I can't think of the word, like a flyer with some information for patients here in the next couple of months. And so, Carissa, I'd love to, connect with you with that information as well and see if that's something that can maybe piggyback on the release of some of this educational information.
Yeah, that'd be great.
All right. Thank you guys so much. I am going to transition us now. Maybe. Okay, come on. I'm not sure how to do this. Anyway, I wanted to just transition us to our next speaker, but I forgot to mention at the beginning of the call that with our speakers and our planning committee that there are no disclosures that we need to speak of. Everything has been mitigated. So without further ado, let me introduce our next speaker, Jared Moore. Jared was born and raised in Idaho Falls. He attended Idaho State University and graduated from the College of Pharmacy in 2012. Upon graduation, he worked at Shopko in Idaho Falls and Costco in Boise before joining Full Circle Health, previously Family Medicine Residency of Idaho, FMRI, in 2016. He switched roles from pharmacy supervisor to director of pharmacy services in 2021. He enjoyed playing sports throughout his childhood, such as baseball, basketball, football, golf, and tennis. And as an adult, he enjoys reading, particularly history, running, biking, studying languages, and traveling. He lives in Meridian, Idaho with his wife, Jessica, and 2 children. So, Jared, thank you so much for joining us. And I am going to turn control over to you. So feel free to share your screen.
Okay. Let's see here. Okay, can we see it?
Yes.
Okay. So yeah, that was, I really enjoyed that presentation by Chris. I appreciate how thorough it was and what it went over, and hopefully my presentation can add to that a little bit. I, like was said, I work at Full Circle Health. Previously, we were called Family Medicine Residency of Idaho. My presentation today is on how we can increase medication access for underserved populations, particularly here in Idaho. And I don't have any conflicts to disclose. I really don't have any expertise except for that I've worked here at Full Circle Health at this FQHC for 6 years in different capacities. I've been the pharmacist at 2 of our in-house pharmacies, and now for the last year, I've been in this role as director of pharmacy, and I've really enjoyed it. And helping people get access to medications is one of my passions. Learning objectives today is to kind of describe what is a FQHC and the 340B drug pricing program. What are some common barriers to medication access, and how do FQHCs increase medication access to our vulnerable and underserved populations. FQHCs, I have this long definition, but essentially they're community health centers that are receiving funding from HRSA. When there's government or HRSA funding, there's all sorts of regulations and requirements that go into that process. Here in the Treasure Valley, the 2 that are kind of the big players as far as FQHCs are Terry Riley and Full Circle Health, where I work. Throughout the state, I know Chaz, that's based out of Spokane, has a location in Lewiston. There's one in Idaho Falls called Community Family Practice. There's one in Pocatello called Health West. Those are just a couple to name some. And we receive, I should say, grant money every year based on how many people that we're serving, underserved. So for example, here at Full Circle Health, our demographics, 50% of our patients are Idaho Medicaid, and about 8 to 10% are uninsured. I know Terry Riley, don't quote me, but I believe their number of uninsured patients is much higher. They're probably closer to 40% uninsured population. And part of the requirements are that you have to have a sliding fee scale for patients based on their ability to pay. You have to have a board of directors that includes patients, and you have to provide expanded services to the underserved and vulnerable populations. And you have to prove that every so often, every 3 years. Being an FQHC or federally qualified health center allows us to purchase medications, drugs at 340B drug pricing. This program was established in 1992 with the Medicaid drug rebate program. So it was at the same time. And the intent is to help covered entities, including FQHCs, to stretch the scarce federal resources as far as possible. It's for outpatient drugs only, and with these discounts, we're able to do a couple of different things with the savings. First of all, for our patients that are uninsured, we can sign them up for sliding fee, and we're able to pass those savings along to them. And then for our commercially paying patients, we're able to bill their insurances at the same rate that a retail pharmacy would be. And those savings or those revenues allow us to expand services that we would otherwise be unable to provide. Some of the things that we're able to provide with those savings or increased revenue is dietitians. We have 2 here at Full Circle Health, social health workers, increased clinical pharmacy services, so that we can provide counseling on CGMs, or we can meet with patients or call patients and follow up with them on insulin titration. Some of the covered entities and that language, this is really kind of getting in the weeds, but just understanding that FQHC is one of the covered entities that can participate in that 340B drug pricing program. So here in the Treasure Valley, St. Al's and St. Luke's also qualify as disproportionate share hospitals for 340B drug pricing. Just a little bit about our particular FQHC or Full Circle Health. Previously, we were Family Medicine Residency of Idaho. We changed that name to Full Circle Health in May of 2022. That was necessitated by the fact that we had grown past the name. For the first 40 years of our existence, we were primarily Family Medicine Residency, but over the last 10 years especially, we've grown. We offer fellowships in sports medicine, geriatrics, addiction medicine, HIV fellowships, and then in this upcoming year, in June of 2023, we're going to be welcoming our first pediatric residency class here in the Boise Valley, here in Boise in the Treasure Valley. So we're really excited about that. We have 8 clinics throughout the Treasure Valley. So we have 3 in Boise, 1 in Kuna, 1 in Meridian, a couple in Nampa. We're going to be opening that pediatric one, and then we just opened our 3rd in-house pharmacy. And so we also have a contract with Idaho for any refugee that comes to Idaho for their first 10 months. We provide their healthcare. So they come to our clinic, and we're able to provide healthcare to them, provide them with immunizations, make sure that they're up to date on everything. And because of that, we have in-house interpreters, and then also we use an in-demand interpreter for some of the languages. We have 43 languages that are spoken at our clinic. And this is obviously my opinion. I have no numbers to back this up, but just from our anecdotal experience with our patients, the biggest barriers to medication access are transportation, so the ability to drive to the pharmacy and pick up, language and cultural barriers, and this would probably be more specific for us, but it can be anywhere throughout the state, and then affordability. Transportation, the way we deal with that barrier is we offer free mailing of medications. We don't mail out controlled substances, and then insulin, we don't mail out refrigerated items like insulin, just because of the cost to ship out coolers would be prohibitive for us at the current time. We are looking potentially in the future at doing a delivering service, but we don't offer that currently. And then language and cultural barriers, we have a number of our staff members that are bilingual. We have 5 staff members that speak Spanish, and then we have a pharmacist that speaks Farsi and Dari. Dari is one of the primary languages in Afghanistan. So for our Afghan refugees, that's been a lifesaver to have her there and being able to counsel them on how to take their medications. But for the meat and potatoes of this presentation, we're going to be focusing primarily on affordability. And Carissa did a really good job on it, explaining some of the different resources. I'll just go into depth on some of the different ones that we utilize here. One of the sources that we use for our commercial paying patients is copay cards. They are for commercial insurance only. Every copay card that I've seen has an exclusion for government programs, specifically Medicaid, Medicare, and TRICARE. They must be U.S. citizens, so that affects some of our population. They typically have monetary limits. So if a drug costs $450, then they'll pay for up to $200. So if the insurance is not paying for the drug, that will take the copay down to $200, which is still not doable for some patients. And then a lot of times you get stuck with the fine print. So one of the newer diabetes medications that's out there is Mounjaro, which has a dual mechanism. It's kind of, right now it looks really promising as far as decreasing A1C and then also really reducing weight. But one of the things that's changed recently is a lot of patients were using it off-label specifically for the weight loss. And Mounjaro has changed the language now so that the copay card is only for those patients that have type 2 diabetes. So you just really have to be careful with the fine print on these copay cards. Idaho Medicaid, and some of this is a little bit of a review of what Carissa had talked about, but I'll be specific for Idaho. In November of 2018, Idaho voters passed Proposition 2 to expand Medicaid services. And so that went into effect on January 1st of 2020, which was fortuitous that it happened at that time, given what would happen in the next couple months. And then, like was stated earlier, it's been a public health emergency due to COVID. And so every 3 months, it's been extended. And we just found out on October 15th that it has been expanded until January 15th of 2023. At that time, they'll reassess whether it needs to be expanded or extended again. But eventually that will go away, and Medicaid will start cleaning the books for patients that have been listed or that currently would not qualify for Medicaid. From a medication standpoint, something that might be interesting is that Medicaid recipients have a zero copay, but sometimes it can be difficult to get things through for a prior authorization. And one of the things that we've had a difficult time with is the durable medical equipment, testing, glucometers, testing strips. As a little pharmacy, we did not have a contract with Idaho Medicaid, but we just changed that. It has been a process, and I won't review some of the things, but the CGM is the next thing that we're going to be focusing on. It doesn't necessarily require a prior authorization, but it does require extensive documentation that the patient is on insulin and they're taking 3 doses a day, that they have been testing themselves 4 times a day. And those are barriers that we're trying to make sure that we're documenting throughout the process for our Medicaid patients. One that to be comprehensive, I included our AIDS drug assistance program. or ADAP. This is for our HIV positive patients. When I started in 2016, their formulary was very narrow. It was pretty much antiretroviral therapy for HIV positive patients. But over the years, that list has expanded, and pretty much any diabetes medication that would be necessary or maintenance medication would be covered under ADAP for our HIV positive patients. And they are considered a payer of last recourse. So it's a program for HIV positive patients once the patient doesn't qualify for Medicaid or any other insurance. Patient medication assistance programs. This is directly through the manufacturer, and each manufacturer has specific requirements. We use a third party called Med Data Services to help us sign patients up. We have a pharmacy technician that works, 4 hours a week. He has time set apart to call patients up that have been flagged by our physicians to call them up. This program used to be much bigger, but as the years has gone by and as more drugs have gone generic, we have less and less patients using this program. Typically, it's used for our hepatitis C medications. Every once in a while, we do have some diabetes medications that we do use PMAP for. Sliding fee program. We have a kind of, as discussed at first, we offer sliding fee for patients that qualify, and it's all based off of income. They have to be at or below 200% of the federal poverty guidelines, and it's household income. And once they qualify, they receive a discount in the clinic. So an example would be like a $10 copay for a clinic visit, an office visit. They're stratified in different tiers, and then they also qualify for discounts in the pharmacy. So we pretty much give them the drug at acquisition cost. We add a small dispensing fee. It's a flat rate of $5. So for most patients, for most medications, we can find a medication in a drug class that's going to cost them anywhere from $5 to $10. And so that's a really helpful for a lot of our patients, and they appreciate being able to buy a 90-day supply of insulin, of Humalog or Lantus or Levemir for $6. What we found over the years that most of our sliding fee patients and Medicaid patients were being covered, but we did have a gap from when our patients that were on sliding fee and then they started to qualify for Medicare, that they would be unable to afford their medications because they had been on paying a flat rate of $6, and then all of a sudden they're having to pay a monthly deductible and higher copays. So our CEO created a We Care Fund to help these patients out, where we will pay for 3 months of their maintenance medications to help them get through the year. It helps particularly with those Part D participants, but then we also have some sliding fee patients that aren't able to pay even the copay for their medications that they have. And the primary goal of this program is to reduce hospitalizations due to non-adherence. And it's been really good. The only drugs that aren't covered really under our We Care are pain medications, narcotics specifically, benzodiazepines, cosmetic medications. It's not going to pay for a patient's Viagra. And then as another option that we have as kind of a last option is to price match. We cannot undercut the competition in the Valley or our local competition, so we can't go below Walmart. But what we typically do is their price plus $1 to make sure that we're not undercutting them. So for example, Walmart offers Novolin MPH, 1 vial for $25. We offer 1 vial for $26. So that is something that we utilize occasionally. If nothing else, if there's no other program for a patient, we'll use the Novolin MPH was the intermediate dose, the No1R, which is the immediate release, and then the 70/30, which is a combination of the two. And then also obviously matching the metformin, which is $5, and then the glimepiride and glipizide or sulfonylureas that are also on that $4, or we call it $5 here list. There's bibliography, and then I will stop to see if there's any questions.
Thank you so much, Jared. This has been really, really helpful. There is a question in the chat box. The question is there a resource to see what diabetes medications are on the 340B formulary? For example, which basal insulin is offered at a discount price?
Great question, and it's one that our residents ask all the time, and the short answer is no. And the reason why is because the prices change quarterly. So I could create a list, but then it would be outdated within 3 months. So for our physicians, we encourage them, hey, if there's any question, just call us up, call our pharmacy, and we have a pretty helpful, friendly team that would be willing to help them figure out. And the thing that's kind of nice about our situation here at the FQHC is our pharmacists have a lot of autonomy. So Idaho pharmacy law is very progressive, and Carissa pointed that out. But where we're all in the same facility, we have even more latitude to switch drugs. So if a doctor wrote for Lantus and Levemir is going to be cheaper for the patient, we kind of have that free range because we have access to the EMR to go in there, change that, and send a note back to the physician. Hey, change this for the patient. Just wanted to let you know. Or, hey, you prescribed Lantus or Levemir, but you forgot to prescribe the pen needles. So I just did that for the patient. And that's been really helpful. Other community pharmacies have that ability with some of those, but frankly, a lot of them don't have the time to do that. That's my experience. Other people can say differently, but a lot of the community pharmacies are understaffed and overworked.
Thank you for that. I don't see any more current questions in the chat box. So if you do have a question, feel free, raise your hand, pop it in the chat box. I'll ask it for you.
And I will add just one more thing, and I didn't include this on the slides because I did some more research this morning because I had heard on a podcast about California looking into insulin, and they are, by 2024, they're looking at producing their own insulin for their state. They're putting $150 million into that, and their goal is to kind of be at that $25 to $35 range for their insulin. So I think California is the 4th largest economy in the world now, and the whole phrase is "as California goes, as goes the nation." So I think it will be interesting to see how it goes over the next few years, because it's one thing that Republicans and Democrats all agree on is that medication costs are really high. The problem is no one has the really fortitude to stand up to the drug manufacturers and the PBMs, the pharmacy benefit managers. It's those two powerful lobbies that have a lot of control as far as drug pricing goes.
I forgot to unmute myself before sharing my screen. I apologize. Well, Jared, thank you so much for your time. I know that time is limited these days, so we appreciate you being willing to jump in and kind of share that Idaho local knowledge with us. And as always, if there are questions that come up, please don't hesitate to send them our way. We're happy to reach back out to our speakers and help address any of those questions that come up. So thank you again.
Time for one more question that's in the chat box.
Oh, good. Okay, great.
The question is, any advice on discussions with payers about the cost of medications? For example, we get a report from Blue Cross about prescribing how cost meds like ultra long acting insulin and GLP-1, high cost meds.
no specific recommendations. I will say that, you know, a lot of them are starting to go generic, which is good, because when generics go, typically it takes about 6 months for a bunch of manufacturers to come online. The problem is, a lot of the problems too is with the PBMs is they'll seek rebates in order to get a insulin on their formulary. They're seeking a rebate from the manufacturer. So it's kind of this, and that's where it gets hard. The real best option, if they're looking for cheap insulin, it's going to be the Novolin MPH, Novolin R, and the Novolin 7030. The disadvantage is that those are in vials; they're not in pens. So, sorry, there's not a real one. And then the GLP-1s is another. It really depends on the patient situation. It depends if they're commercial insurance, Medicaid, or uninsured.
Thank you for that.
Any other questions? All right. Then let's just move into some final housekeeping items. Oh my goodness, how did I do this before? Okay. Here we go. Okay, as mentioned before, continuing education credits are available if you attended today's live virtual training. So following this training, give us a couple days, but we will be getting a post-evaluation sent out to all attendees. Please complete that evaluation and submit it back to us via email, and then you will receive your certificate of completion. If you have any questions regarding continuing education, please don't hesitate to send us an email, and we will do our best to address them accordingly. And finally, just another thank you to our presenters for taking the time to share with us today. Thank you to those who were able to join us live. And again, this is being recorded, so this will be made available to DAI members, and an email will be sent out with the link to access it in the next week or so. So again, without further ado, we'll let you guys get back to your day, and be sure to keep in touch with us via our newsletter on our website for any other upcoming trainings. And you guys have a great rest of your day.